Welcome to Katab Podcast. This is episode 24. Last time, we really got familiar with the pelvic cavities framework. The bones, like the sacrum, coccygeal, hip bones, and those tough ligaments defining the greater and lesser pelvis.
We did. We set the stage, defined the boundaries. Today, we're diving inside that framework. We're going deep into the structures actually running through it.
Right.
So the neurovasculature nerves and blood vessels, and also the terminal parts of the urinary and digestive systems that sit right there in the pelvis.
Okay, so we're shifting from the architecture to the plumbing and wiring, basically. I gather this area is pretty crowded and complex.
That's putting it mildly. It's a real challenge, both for learning and in the clinic. You've got major arteries, major nerves, and the end portions of 3 vital systems all packed into the lesser pelvis.
Wow.
So understanding exactly where everything runs, the blood flow pathways, the nerve supply, it's absolutely critical, not just for exams, but for avoiding some really serious surgical problems. Maybe we can think about it in terms of redundancy versus vulnerability.
Redundancy versus vulnerability. Okay, I like that theme. Let's start with redundancy then and talk about the arteries. The source says the pelvis is richly supplied with lots of connections and anastomoses for collateral circulation.
Exactly. That phrase, extensive collateral circulation, is, well, it's reassuring, isn't it?
Yeah.
It means if one blood vessel gets blocked or tied off, maybe during surgery to stop bleeding, there are usually other routes for blood to get where it needs to go.
So backup routes.
Backup routes, precisely. And the main source for all this is the internal iliac artery. No question.
And that one immediately splits into 2 main branches, anterior and posterior divisions.
That's the standard description, yes.
Yeah.
Typically, the anterior division handles the pelvic organs, the viscera, and the perineum down below.
Right.
While the posterior division tends to supply the muscles of the pelvic walls and the gluteal region, the buttocks.
Makes sense.
And this is a huge but for clinical practice, the way these branches come off the internal iliac. It's incredibly variable.
So not always textbook perfect. That sounds like a potential headache during surgery.
It's something surgeons always have to keep in mind. For instance, you might learn that the inferior gluteal artery, which is a big one, comes off the anterior division.
Right.
But in maybe close to half the population, it actually rises from the posterior division.
Right.
So if you're operating and expecting it in one place, well, things can get confusing fast.
Yeah.
The key point is, the names of the arteries are consistent, but the exact origin point, the pedicle, that varies.
Got it. So know the names, but be prepared for different starting points. Let's track the main branches off the anterior division first.
Okay. First up is the umbilical artery. Now, in a fetus, this is vital, carries deoxygenated blood away. But after birth, the far end of it mostly closes off.
Right. It becomes a ligament.
It becomes the medial umbilical ligament, just a fibrous cord. But the part closer to the internal iliac stays open, it's patent, and it gives off some important branches itself.
Does that ligament remnant cause any issues or have any use?
Not usually issues, but it's relevant. The superior vesical arteries, supplying the top of the bladder, come from that open proximal part. And sometimes, though rarely, that closed-off distal part might not fully fibrose, which could theoretically cause problems. It's also a landmark.
Okay. Then we have the obturator artery running along the side wall.
Yep, heading towards the obturator foramen.
And in females, the really key visceral branches, the uterine and vaginal arteries.
Oh, the uterine artery is a major one. It runs medially within the base of the broad ligament that supports the uterus. We absolutely have to talk about its relationship with the ureter later.
Okay, the water under the bridge thing.
That's the one. Now, the vaginal artery, it's considered the equivalent of the inferior vesical artery in males. But interestingly, in females, it often doesn't branch directly off the internal iliac. Yeah, frequently it comes off the very beginning of the uterine artery. And it supplies the vagina, obviously, but also sends branches up to the base, the fundus, and neck of the bladder. So again, very close relationship between uterus, ureter, bladder supply. Requires real precision in surgery like hysterectomies.
Makes sense. We also see the internal pudendal artery branching off here.
Right, that one's heading down to the perineum. We'll cover that region in detail next time.
And the middle rectal artery.
Another example of redundancy for the gut. It helps supply the rectum. And like many pelvic arteries, its origin is flexible. It might come straight off the internal iliac or share a starting point, a common trunk, with the inferior vesicle or the internal pudendal.
So multiple potential origins ensuring the rectum gets blood.
Exactly. It contributes to this sort of 3-pronged supply to the rectum, which really guarantees good blood flow.
Okay, let's switch over to the posterior division branches. These sound like they're more for the pelvic walls and muscles.
That's generally true. The main ones here are the lateral sacral arteries, usually a superior and an inferior pair.
And they're important because
They supply the muscles nearby, like piriformis. But critically, they send spinal branches through the anterior sacral foramina, those holes in the sacrum.
to the nerves.
Yes, to the spinal meninges covering the nerve roots, and to the sacral nerve roots themselves. They're vital for keeping those nerves, like the roots forming the sciatic nerve, supplied with blood. They also send branches out the back, through the posterior sacral foramina, for the back muscles and skin.
And the biggest branch off the posterior division.
That's the superior gluteal artery. It's a large vessel. Its exit path is quite consistent. It squeezes between the lumbosacral trunk nerve bundle and the S1 nerve root, heading straight out to the gluteal muscles.
A tight spot. Surgeons need to be careful there.
Extremely careful. It forms a major neurovascular bundle with the nerve.
Okay, so that covers the internal iliac system. Are there other arteries contributing significantly to the pelvis?
Yes, a couple of important ones not from the iliac system. First, the median sacral artery.
Median sacral.
It's usually small, unpaired, and comes off the back of the aorta, just above where the aorta splits into the common iliacs. It runs straight down the midline on the fronts of lower lumbar vertebrae and the sacrum.
So it's a good landmark.
A very reliable landmark, especially in laparoscopic surgery. And embryologically speaking, it's pretty neat. It represents the very tail end of the embryonic dorsal aorta, kind of a leftover from our tailed ancestors.
A little evolutionary reminder. And the other major artery, you mentioned it supplies the rectum.
That's the superior rectal artery. It's actually the continuation of the inferior mesenteric artery from the abdomen. It descends into the pelvis to supply the upper part of the rectum.
Okay, so a rich, interconnected, but variable arterial supply. Now, you mentioned redundancy versus vulnerability. If the arteries show redundancy, where does the vulnerability come in? Maybe with the veins.
Exactly. The veins, especially the venous plexuses, present a different kind of challenge, a potential danger zone.
Let's talk about pelvic venous plexuses and drainage then.
So the veins mostly travel with the arteries, and they generally drain into the internal iliac veins. But they don't form simple single trunks like the arteries often do. Instead, they create these extensive, interconnected networks, plexuses.
Like a web of veins.
A dense web. The vesical venous plexus around the base of the bladder is a key one. And in males, this connects with, and is basically continuous with, the prostatic venous plexus.
Prostatic plexus? How big is this combined network?
It's massive in males. It surrounds the bladder base, the prostate gland, the seminal glands, even the lower parts of the ureters. And importantly, it receives the deep dorsal vein of the penis.
Okay, so a lot drains into this complex. Where does it go from there?
Mostly drains via the inferior vesical veins into the internal iliac veins. But here's the critical, potentially dangerous connection. This whole vesical prostatic plexus is directly connected to the internal vertebral venous plexus. You might know it as Batson's plexus.
Batson's plexus, I remember that. It runs along the spine right there, and it doesn't have valves.
Precisely. Valveless. That's the key vulnerability. Because there are no valves, blood flow isn't strictly one way. If pressure increases inside the abdomen or pelvis, say, from coughing, straining, even lifting something heavy, blood can actually flow backwards from the pelvic plexuses up into the vertebral plexus.
So it's a potential route for things to travel upwards.
A direct low-resistance highway. It allows things like cancer cells, especially from prostate cancer, which is right there in the plexus, to spread directly to the vertebrae, the spinal column, and even potentially up to the brain.
Bypassing the lungs and liver filters.
Bypassing the usual filters. It's a major pathway for metastasis, making that venous network a point of significant clinical concern.
Wow. Okay, that really highlights the vulnerability aspect. Let's shift gears slightly to the lymphatic system and nerves. How does lymph drain from the pelvis?
Lymph drainage tends to follow the veins, heading towards the major arteries. So the main collection points are the internal iliac lymph nodes. Often lymph first passes through smaller sacral lymph nodes located near the sacrum before reaching the internal iliac group.
But not everything goes there. You mentioned an exception for higher up structures.
That's right. Structures located more superiorly and anteriorly in the pelvis, like the top part of the bladder, or things near the external iliac vessels, tend to drain directly to the external iliac nodes instead.
So two main initial drainage sites depending on location.
Correct. Internal and external iliac nodes. This distinction is really important for cancer staging. Knowing which nodes might be involved tells you a lot about the spread. From both sets of iliac nodes, lymph then flows up to the common iliac nodes and then ultimately to the lumbar nodes along the aorta and vena cava in the abdomen.
Okay. Now, for the nerves, the somatic nerves first, we're talking sacral and coccygeal plexuses lying on muscles.
Yes, they rest on a muscular bed formed by the piriformis and coccygeus muscles. The whole system gets its upper input via the lumbosacral trunk.
The lumbosacral trunk, what exactly is that?
It's the connection. It's formed by the anterior rami, the front branches,
Hmm.
of the L4 and L5 spinal nerves coming down from the lumbar region. It bridges the gap, carrying those fibers down to join the fibers from S1, S2, S3, and S4, which form the main sacral plexus.
So it links the lumbar plexus output with the sacral plexus.
Precisely. It's the critical link.
Now, the source mentions the obturator nerve as being particularly vulnerable during surgery. Why is that?
It's all about location. The obturator nerve runs along the lateral wall of the pelvis, right next to where surgeons might be working, especially during procedures like removing lymph nodes near the iliac vessels.
So it's easy to damage accidentally?
It can be easily stretched, nicked, or even cut during aggressive pelvic surgeries, like for cancer, where you need to clear out tissue and nodes thoroughly.
And if it is injured, what happens clinically?
You get both motor and sensory problems.
Mm.
Motor-wise, the patient experiences painful spasms in their thigh adductor, the muscles on the inner thigh because the obturator nerve supplies them. Yeah. And sensory-wise, they'll have numbness or altered sensation on the medial, the inner side of their thigh. It's a known and unfortunately not uncommon complication that surgeons actively try to avoid by careful dissection.
Okay. What about the big nerves coming from the sacral plexus itself, sciatic and pudendal?
Well, the sciatic nerve, formed from L4 down to S3, is the giant.
Okay.
It's the largest nerve in the body.
Right.
It leaves the pelvis and supplies almost all the muscles and sensation in the lower limb below the hip joint. So any significant damage to its roots within the pelvis, say from a tumor or injury, has massive consequences for leg function, knee flexion, all ankle and foot movements.
Huge impact. And the pudendal nerve, S2, S4, it seems smaller but sounds functionally critical.
Absolutely critical. It's the main nerve for the perineum, the area between the legs containing the external genitalia and anus.
Yeah.
It provides sensation to the external genitals.
Okay.
And vitally, it controls the key muscles for continence. The perineal muscles, the external urethral sphincter, controlling urine flow, and the external anal sphincter, controlling bowel movements.
So essential for bladder and bowel control.
Foundational. Damage to the pudendal nerve, perhaps during childbirth, can lead to incontinence, which is why it gets a lot of attention in OBGYN and urology. Nerve blocks targeting it are also used for pain relief.
That leads us nicely into the autonomic nerves, the automatic control system for the pelvic organs. Sympathetic and parasympathetic inputs forming plexuses.
Yes, it's a complex interplay. The sympathetic nerves mostly come down from the abdomen as the sacrosympathetic trunks. They run down along the sacrum and usually meet at the bottom, in front of the coccyx, forming a little knot called a ganglion impar.
And what's their main job down here? Is it the organs?
Primarily, no. Their main role in the pelvis is actually to send sympathetic fibers out to the lower limbs. They control blood vessel constriction, bursa motor, hair standing on end, pilomotor, and sweating, pseudomotor, in the legs and feet.
Interesting. So if sympathetics are mostly for the limbs down here, the parasympathetics must be handling the pelvic organs?
That's right. The parasympathetic supply comes from the S2, S3, and S4 spinal cord levels via the pelvic splanchnic nerves. These are the rest and digest nerves for the pelvis.
Okay.
They bring the parasympathetic signals to the inferior hypogastric plexuses. These are dense networks of nerves draped over the pelvic organs. This is where sympathetic and parasympathetic fibers mix to control things like bladder contraction, rectal peristalsis, and importantly, erectile function in males.
Okay, so a mix of inputs in those plexuses. Now, there's this concept that ties sensation from the organs to these autonomic pathways. The pelvic pain line. It's not a real line you can see, is it?
No, it's a physiological concept, but incredibly useful. It's an imaginary line related to the organ position relative to the peritoneum, the lining of the abdominal cavity, and it determines which nerve pathway pain signals from that organ will follow.
How does that work?
Okay, if the pain originates from an organ or part of an organ that is superior to this pelvic pain line, take upper bladder, uterine body, sigmoid colon, the pain signals travel backwards along the sympathetic nerve pathways.
Following the sympathetics back up, towards which spinal levels?
They track back to the lower thoracic and upper lumbar spinal cord segments, roughly T11 to L2. So the brain interprets the pain as coming from the body wall areas supplied by those levels, the lower abdomen or flank region. That's referred pain.
Like appendicitis pain starting near the navel.
Exactly. But if the pain comes from below the pelvic pain line, like the cervix, the lower bladder, the anal canal, the pain signals travel with the parasympathetic pelvic splanchnic nerves.
And where do they end up?
They go directly back to the sacral spinal cord segments, S2 to S4. This results in pain that feels more localized to the pelvis, perineum, or genitals. It's often sharper. Understanding this line is key to figuring out where a patient's internal pain might actually be coming from.
That's a really important clinical concept. Okay, let's apply this neurovascular knowledge to the organs themselves, starting with the ureters as they pass through the pelvis.
Right after their long journey down from the kidneys, the ureters enter the pelvis, run down the side walls, and then curve forward and medially to enter the bladder. Their relationships here are critical.
Especially in females with the uterine artery.
Yes, that's the big one. The ureter passes inferior to the uterine artery. Water under the bridge, ureter is water, artery is bridge.
Got it.
This close crossing point makes the ureter vulnerable during pelvic surgery, particularly hysterectomy. If the clamp placed on the uterine artery is too wide or dissection isn't careful, the ureter can easily be accidentally clamped, tied off, or even cut.
Leading to blockage or leakage.
Exactly. And speaking of damage, the source makes a really crucial point about the ureter's blood supply and how easily it can be damaged without even cutting the ureter itself.
This sounds important. Tell me more.
The ureter gets blood from multiple small branches along its length, a good setup. But the direction those branches come from changes. In the abdomen, the blood supply tends to come from the medial side, from renal gonadal arteries. But in the pelvis, the blood supply primarily comes from the lateral side, from branches of the internal iliac system.
Laterally in the pelvis. Why is that difference so critical?
Because during surgery, if a surgeon pulls the pelvic ureter strongly towards the midline, maybe to get better access to something else, they can stretch or tear those delicate blood vessels approaching from the lateral side.
Okay, I see.
The ureter itself might look perfectly fine at the end of the operation, but because its blood supply has been compromised, that segment can die off over the next week or so.
Die off, leading to?
Delayed rupture. About 7 to 10 days post-op, the ureter can necrose, break open, and start leaking urine into the pelvic cavity. It's a serious delayed complication resulting purely from disrupting that lateral blood supply.
A sobering reminder of anatomical detail. Okay, let's look at the urinary bladder itself. Hollow, muscular, changes size a lot.
Hugely variable. When it's empty, it sits down low in the lesser pelvis, protected behind the pubic bones. But as it fills with urine, it expands upwards, rising above the pubic symphysis into the greater pelvis, even pushing into the lower abdomen.
And that upward expansion is clinically useful, isn't it, for accessing the bladder?
Absolutely.
Yeah.
The key is that the very top of the full bladder is covered by peritoneum, but the front part, right behind the pubic bone, is not. It's extraperitoneal.
Meaning?
Meaning a clinician can insert a needle or catheter directly through the lower abdominal wall, just above the pubic bone, into a full bladder without going through the peritoneal cavity. It's a suprapubic cystostomy. It's a safer way to drain the bladder if you can't pass a catheter up the urethra.
Clever. Inside the bladder, what's the trigone?
The trigone is a smooth, triangular area on the internal back wall of the bladder base. Its corners are the two openings where the ureters enter and the single opening where the urethra exits, the internal urethral orifice.
And it's smooth, unlike the rest of the bladder lining.
Right. The rest of the bladder lining has folds called rugae, which allow it to stretch. But the trigone's lining, its mucosa, is firmly stuck down to the underlying muscle. It stays smooth and relatively fixed in position, even as the bladder fills and empties. It reflects its different embryological origin.
Interesting. Okay, let's follow the urine out into the proximal male urethra. This is where urinary and reproductive paths meet.
Correct. In males, the urethra starts with a very short intramural part, just passing through the bladder wall itself. Then comes the crucial prostatic urethra.
Prostate because it runs through the prostate gland.
Exactly. It's completely surrounded by the prostate. And this segment is the junction box. Urine flows down from the bladder, but also the ejaculatory ducts, carrying sperm and seminal fluid, open into it, as do numerous tiny ducts from the prostate gland itself.
So problems with the prostate, like enlargement or cancer, are bound to affect urination and sexual function.
Directly. Benign prostatic hyperplasia, BPH, very common in older men, squeezes the prostatic urethra, causing symptoms like difficulty starting urination, weak stream, needing to go often, especially at night. Its nerve and blood supply, from inferior vesicle, middle rectal arteries, prostatic nerve plexus, are all tied up in this area too.
Makes sense. The female urethra is much simpler, though.
Much simpler and much shorter, only about 4 centimeters long. It runs down fused to the front wall of the vagina. Its shortness is its main clinical feature
Why?
because it provides a very short path for bacteria from the outside to travel up into the bladder, which is why women are much more prone to urinary tract infections, UTIs, than men.
Ah, okay. Let's turn to the end of the line for the digestive system, the rectum. It starts where the sigmoid colon finishes.
Yes, usually around the level of the third sacral vertebra, S3, and there's a key change in the muscle structure right there.
What's that?
The sigmoid colon has those 3 distinct bands of longitudinal muscle called tennae coli. When it becomes the rectum, those bands spread out and merge to form a complete, continuous outer layer of longitudinal muscle all the way around.
Why the change?
This complete muscle coat provides the strong, uniform contraction needed for defecation, for pushing feces out. Inside, the rectum isn't just a straight tube. It has curves and some internal folds, transverse rectal folds or valves that help support the fecal mass. The final section dilates to form the rectal ampulla, where feces are stored just before defecation.
We touched on its blood supply earlier, 3 sources contributing.
Yes, reflecting its importance. Superior rectal artery, from the inferior mesenteric, supplies the upper part. Middle rectal arteries, from the internal iliac, supply the middle and lower parts. And inferior rectal arteries, from the internal pudendal, supply the very bottom, the anorectal junction and anal canal. Great collateral supply.
Okay. But the veins draining this area have that special arrangement, the portal systemic anastomosis. Can we break that down?
Absolutely. This is a classic anatomical setup with major clinical implications. The veins within the rectal wall form an internal rectal venous plexus. Now, the drainage above a landmark called a pectinate line goes upwards via the superior rectal vein into the inferior mesenteric vein, which is part of the portal system blood heading to the liver.
Okay, upper part drains to the portal system. What about below the line?
Drainage below the pectinate line goes via the middle and inferior rectal veins into the internal pudendal and internal iliac veins, which are part of the systemic or caval system blood heading back to the heart via the vena cava, bypassing the liver initially.
So 2 different drainage routes meeting right there.
Exactly. It's a natural connection point between the portal and systemic venous systems.
Yeah.
Normally, it's not a major flow pathway. But if pressure builds up in the portal system, the classic cause is liver cirrhosis, leading to portal hypertension.
The blood needs another way out.
It backs up and finds this alternate route through the rectal veins into the systemic circulation. The problem is, this increased pressure and flow causes the veins in that internal rectal plexus to swell up and dilate.
Which are internal hemorrhoids.
Precisely. That portal systemic connection is why portal hypertension is a major cause of internal hemorrhoids.
Fascinating connection. Let's pivot to some of the clinical scenarios highlighted in the source material, starting with ureteric calculi kidney stones in the ureter. The pain is described as severe colicky.
It's awful pain because the smooth muscle in the ureter wall above the stone goes into spasm, contracting intensely hyperperistalsis, trying to push the stone along. Plus, the blocked urine backs up, stretching the ureter and kidney pelvis, which also hurts.
And the pain famously travels from loin to groin.
That description captures the referred pain perfectly. It starts in the flank, loin, reflecting the T11L2 nerve roots that supply the ureter via visceral afferents. As the stone moves down, the pain seems to migrate downwards and forwards towards the groin.
Can it radiate elsewhere?
Oh, yes. It can radiate down into the upper inner thigh, involving the genitofemoral nerve territory, or even right into the scrotum or labia. It follows the stone's path.
And stones tend to get stuck at specific narrow points.
Yes, there are 3 common sites of natural constriction where stones often lodge. First, where the ureter leaves the kidney's collecting system, the ureteropelvic junction, UPJ.
Okay.
Second, where the ureter crosses over the external iliac artery as it enters the true pelvis, crossing the pelvic brim.
Right.
And third, where the ureter passes through the actual wall of the urinary bladder. It takes an oblique path, narrowing as it goes. These are the hot spots urologists look at.
Makes sense. Now, shifting to problems with pelvic support, cystoscopy and pelvic organ prolapse. What's failing here?
The primary failure is in the pelvic floor muscles, mainly the levator ani complex and the connective tissue, the fascia, that supports the pelvic organs.
What causes that weakness?
The most common culprit is damage during childbirth stretching or tearing of the muscles, especially the pubococcygeus part of levator ani, or damage to the fascial supports laterally, the pericarpium. Age and chronic straining can contribute too.
And a cystocele specifically involves the bladder.
Yes. Cysto refers to bladder. Cele means hernia or prolapse. The support between the bladder and the anterior vaginal wall weakens, allowing the bladder to bulge downwards, pushing the front wall of the vagina out.
And the main symptom is often
Urinary stress incontinence. Because the bladder, neck, and urethra lose their normal support, any increase in abdominal pressure, coughing, sneezing, lifting can cause involuntary leakage of urine.
The source also mentioned the perineal body as being vital for overall support.
It's crucial. The perineal body is a central fibrous muscular point in the perineum, between the vagina scrotum and the anus. Several muscles converge and attach there. Bulbospongiosus, external anal sphincter, superficial transverse perineals, and fibers from levator nani.
Like a central anchor point.
Exactly. It anchors everything together across the pelvic outlet. If the perineal body is significantly damaged, maybe from a bad tear during delivery or a poorly repaired episiotomy, that central support is lost, dramatically increasing the risk of prolapse of multiple pelvic organs.
Okay. Lastly, let's circle back to hemorrhoids, specifically internal ones. We know they relate to that venous plexus.
Yes, internal hemorrhoids are basically swollen, prolapsed veins from that internal rectal venous plexus located above the pectinate line inside the anal canal. They happen when the supporting tissue, the anal cushions, breaks down or slips, often due to chronic straining, constipation, or that increased portal pressure we discussed.
And the key clinical difference, tying back to nerves.
It comes back to the pelvic pain line, or really the pectinate line, which corresponds roughly to it here. Internal hemorrhoids are above the line. Therefore, they are covered by mucosa, innervated by visceral afferent nerves, traveling with parasympathetics back to S2, S4.
Meaning they aren't very painful.
Relatively insensitive to pain, touch, or temperature. So patients usually present with painless rectal bleeding, perhaps noticing blood on the toilet paper. This is very different from external hemorrhoids, which are below the pectinate line, covered by skin with somatic innervation, and are extremely painful when thrombosed or inflamed.
That innervation difference is key for diagnosis.
Absolutely fundamental.
Well, this has been a fascinating journey through the inner workings of the pelvis. We covered the arteries, highlighting the internal iliac's variability and the crucial ureter-uterine artery relationship.
And the veins, especially the dangers of Batson's plexus connections.
Right. Then the nerves, the vulnerable obturator, the vital pudendal for continence, and that all-important pelvic pain line concept dictating where visceral pain is felt.
And applying it all to the ureters, bladder, urethra, and rectum, including those key clinical issues like stone obstruction, prolapse, and the portal systemic link with hemorrhoids.
It really underscores how interconnected everything is down there.
It truly does. And perhaps a final thought, tying back to that pelvic pain line again. Think about pain relief during labor or pelvic surgery. Pain from the uterine body above the line travels via sympathetics to T11L2. Pain from the cervix and vagina below the line travels via parasympathetics to S2, S4.
Okay, so
How effective would a standard epidural anesthetic, usually placed in the lumbar region, be for blocking pain from the upper structures versus pain from the lower structures? Does it cover both equally well? It shows how understanding these distinct nerve pathways is crucial even for planning anesthesia and managing pain effectively.
that's a great point. It really emphasizes how this anatomy directly impacts clinical decisions every day.
Couldn't agree more. Now, next time in our final deep dive on this region, we'll move down just a bit further to focus solely on the perineum, the external structures, the urogenital and anal triangles in both males and females.
Looking forward to it. Thanks for listening to Key Top Podcast.